Top Bed Talk.
Welcome back to EBPOM Ireland Chicago 2021. I'm Monty Mythen, and I'm here anchoring in our main studio, which is on the west coast of Ireland in the magnificent Dingle Skellig Hotel. But meanwhile, back in virtual Chicago, where Dr. Aronson is our lead.
We have a pretty exciting session coming up, Monty.
We do, a smoking cessation.
Something that we all can relate to. I'm sure all of our patients, all of our encounters with patients see this frequently. And so before we get started in the session, it's worthy of us just give a quick shout out to Dr. James Davis, who, is really the sort of impetus behind the smoking cessation program at Duke in general, and certainly our partner to develop the perioperative smoking cessation program. But it wouldn't happen without the people with boots on the ground. I'm going to bring in the other guests to this panel because I think they offer some really important perspective. Dr. Toby Richards and Sher-Lu to also join us, if I may. It's the smoking cessation is not a simple one size fits all. It's not call a 1-800 number. It's not, chew this piece of gum and call me in the morning. But we really take a personalized approach and respect that everybody has their own reasons and issues that have to be dealt with. And I think your perspective in this program really addresses that. Jillian?
Yeah, I think you're absolutely right. It would be, I think, much easier if we could say there's one pill, there's a shot you can take, there is just one thing you can do, and then it's resolved. But what we have really learned is the importance of having that menu of treatment options, because our patients, even when we offer them what we think is the best treatment, they may not be able to engage or interested in engaging. And so having second and third line options has been so important.
Andrea, one of the things that I learned so nice from James when we first started this program is he sort of put it in perspective by sort of laying the foundation that the people who want to quit smoking have quit. And what's left, particularly those who come to surgery, are those people who are hard to manage, that they're the ones who would kind of like to quit, but for all kinds of different reasons are finding it really hard to quit. And so they really require a much more personalized approach. Would you agree?
I would agree with that. I think a lot of patients that I sit with would love a step 1, 2, 3 approach, but they have run into barriers, and that's why they haven't quit yet. And so sometimes we have to unpack where they're getting stuck, unpack why they aren't able to make it to the next stage of change, or what their barrier is. Maybe it's a mental health concern or something else that they have to kind of process before they're able to see further success with their smoking cessation.
And I see we do have our guests now entering into the virtual room on the virtual couch. And so I'm going to ask you both to introduce yourselves. I'll start with Sher-Lu, if you could just sort of give us a brief introduction of who you are and your connection to the smoking world.
All right. Hello, my name is Sher-Lu. I am a physician at Mayo Clinic in Florida. I have been a director for the Preoperative evaluation clinic for the last 7 years. I also work in the operating room as an anesthesiologist, so I do take care of patients scheduled for surgery from ambulatory to liver transplantation. But it does help when I do get this continuity of care that I see them pre-op for optimization, and I do see them during the perioperative period. We do have everything from anticoagulation to smoking cessation, prehabilitation, all that in line for all our surgical patients.
And Toby, introduce yourself wearing the hat of somebody who's invested in smoking cessation.
Well, it's a double-edged sword. So I'm a vascular surgeon, so I rely heavily on professional smokers for my career. And so we deal with the after effects of smoking both on the elective or 50% of our workload is urgent. And my approach is very much from a factual point of view, because In the setting of vascular surgery, we can put hard facts onto the impact of smoking and the outcomes for the patients.
So I'm going to start with you and then work our way around the room. Years ago, I was in a conference, I don't remember where or who, but I do remember the conversation, and it was with a surgeon, and it went something like this. He said, I don't have a problem, it was a he, with my patients smoking before surgery because I just tell them to stop, as if there was some, Escalabian, authority that came down when the clouds parted, and the surgeon said, just stop, and that was enough. I do think it's really, really important that the surgeon, through that surgical patient relationship, begin the process of motivating the patient to go into a process, however complex that process may be. What do you do and how do you manage that?
So there are two aspects, and I'm looking to my work as a vascular surgeon. For the patients that walk in the door, essentially with rest pain or gangrene to the foot, then it's actually part of the decision-making process of whether or not you're going to revascularize this patient or whether or not this patient may be heading towards an amputation. Our aim is to try and preserve the limb, but also to preserve the life of the patient, ideally with two legs on, but sometimes you need to remove the leg to preserve the life. Now, the risk factor modification comes into that because the facts are quite simple. If we're going to do a 4 to 6 hour operation of a lower limb bypass, the longevity of that is about 60% at 5 years in a non-smoker. And it's threefold less in an active smoker. So the patient and their relatives do take that on board. And we're not looking at 30%. We're looking at, if you're a smoker and you're having a distal bypass, there's probably not that much point having a distal bypass because you'll only end up with 2 operations. Now, in the elective setting, it's a very different kettle of fish. If we're dealing with someone who's got intermittent claudication, that's a lifestyle disease. And there are really only 2 questions for that patient. What do they want? i.e., how far do they want to walk? We all want to be able to run a marathon, particularly after COVID, but the reality is not that. It's possible. Walking 200 yards or 300 yards is adequate for most people. If they have to stop for a couple of minutes after walking from their car to the supermarket, etc., that's often enough. The second thing is, what are they worried about? And what they're worried about is losing their leg. And again, the facts speak for themselves. If you're a smoker and you stop smoking, 2/3 of people will never require any intervention on their peripheral vascular disease, and less than 5% will ever lose their leg. And just take those numbers and triple them if they continue to smoke. And a sensible discussion with the patient and also with the relatives. There's no point the husband or the wife stopping smoking if the spouse on the other side doesn't stop smoking as well. So there's my preamble and introduction on smoking.
Sher-Lu, are facts enough to motivate a patient to stop smoking? And Jillian and Andrea, I'm going to give you a chance to answer that question as well.
We are definitely fortunate enough that our surgical colleagues have been the one that will start the conversation, as they're the one that will schedule the surgery and consult us for pre-op optimization. And what we have found before is that we will provide some very specific complication that's related to the surgical procedure the patient is scheduled for. Especially, for example, plastic surgery that will mention your scar is not going to be beautiful, and it might be not symmetrical after the surgery. And eventually, I think even the surgeon will say, I'm not going to operate on you because you smoking is going to mess up my beautiful artwork on you. And only if you quit, I will operate for the absolute elective procedures. And for general surgery patients, if there's any anastomosis, we tell them there could be a leak. You'll be leaking from the inside. And I know that Toby already mentioned vascular surgeon. Our vascular surgeon also mentioned, hey, this is the procedure we might do, but eventually you might lose a limb because you continue to smoke. So when they come to our clinic, a lot of them already had that conversation. As much as they deem it unpleasant, we're going to continue that conversation. And we even look into, I think back in 2015, we kind of do a survey afterward to see how many percent of the patient after those hard conversations continue to not smoke. I believe after 1 month, maybe 30%. After 3 months, it's about 18%. It's not 100%, but at least it's better than zero. So I think those conversations definitely encourage the patient.
I agree. It is important that you have the surgeon conversation to initiate the motivation. I want to dunk a basketball, but I am not tall enough and I'll never be able to do that. I guess what I'm trying to say is who out there does not yet know that smoking is bad for your health? So the facts notwithstanding, I'm trying to bait the discussion aren't enough. And so, Jillian, what do we do next? Because I'm going to sort of bait the question by suggesting that facts are not enough. And how do we get them over that next step to truly be able to quit?
I will say I think facts are important. Just to share my own experience with a patient who was admitted after an MI, and I went into his room and said, let's talk about smoking cessation. And he said, no, I'll quit when it starts to impact my health. This is somebody who had an MI, 24 hours before, right? That there's obviously some gaps in education and personalized advice about here is how this is going to impact your health, not you might get lung cancer in 30 years. That's really very helpful. But what we need after that is, and here is what you can do to prevent these negative health outcomes. And connecting people to effective treatment. And that step one is giving that fact about here's how it's going to impact you if you don't quit. And step two is here's a resource to help you quit. And here's how that can help your health. Here's how it will help you.
Adrian, your thoughts on that?
I also think one of the elements we're talking about is the difference between knowing and doing. I think a lot of times, in the classroom, we learn the material, but we get out there and experience it, and it's so different. And I think the same is for the patient, even in Jill's example. He hadn't connected that the MI could have been triggered by smoking and how it's affecting his health. I think we don't see it. We can see what's happening in other people so much quicker. And so that's where I sit with patients and really draw them out and help them kind of see that disconnect between what they know and what they do. And that's that complex thing of how interconnected our thoughts, feelings, and actions of smoking are. Yeah, so many patients have highly associated these emotions with smoking. And so they don't realize how closely attached their thoughts, feelings, and smoking behaviors are. And sometimes they have to unpack that. I also just recently, I lead a mindfulness training for smokers group, and it's an 8-week group, and 7 weeks in the class yesterday, they were saying we practice and learn mindfulness skills and actively practice them and quit smoking together. And the group just yesterday, they were saying, we just thought you guys would just tell us facts about how smoking is bad for us, but you're actually giving us tools and helping us practice them and implement them. And it is by far nothing I've ever experienced with smoking cessation before. And so I don't think that is to downplay how other providers have tried to offer tobacco treatment, but I think it also shows that disconnect between having knowledge but actually practicing it.
One of the things that I think surprised me when we started this program, Jillian, as you recall, we were expecting even the great numbers that James had seen in his other non-surgical clinics be overshadowed by the greater numbers that we were expecting in the perioperative space, because the teachable moment of surgery and all those wonderful things that we thought were going to just make this even more attractive and sticky and enduring. And in fact, we didn't see that. The numbers are pretty much aligned with what we would have seen otherwise. At least that's how I recall. One of the points that came up is there was a cadre of patients who said, quite frankly, I don't really want to begin going through the process of stopping smoking before surgery because it relaxes me. And I got enough on my mind because I'm stressed out about my impending surgery that I don't want to further exacerbate my stress level by trying to now quit smoking. Bizarre, but I guess if you peel it back, it may make sense. How do you deal with that patient, Andrea?
That's where we start to look at the function of their smoking. We really take it from an addictions lens. The example I gave in the video, the woman being able to name that she smokes to manage her anxiety and that anxiety was increasing because of the upcoming surgery, that helped her kind of connect the dots and start to be more present with her smoking behavior, be more present with her anxiety. And what we aren't present with, we can't change. We have to be able to name and accept what's happening, the anxiety, smoking because of anxiety, instead of responding in denial and ambivalence. And so really helping her unpack it, put it together so that she can then start using the interventions to be able to manage stress in a different way and effectively decrease smoking at the same time.
Toby, I saw your hand up. Thoughts?
Thanks. I think one thing we focused on is what we're doing to tell the patient what to do. Whilst providing the facts, I also very much believe in giving the patient their own autonomy to make their own decisions. And in doing that, in the preparation for surgery, I say, well, look, these are the things that I'm going to do. These are the things I need you to do to meet me halfway. Stopping smoking for 2 weeks prior to surgery will reduce your risk of chest infections. And that's relevant because I want you to go to prehabilitation with the respiratory physio. And after surgery, for instance, every time you think what time it is, I want 10 deep breaths and a cough. So the patients are scared. They have an average of 9 appointments prior to surgery. But during that process, they get depersonalized. And actually, if you give the patient information for them to do something themselves, I think that does empower them, and they can then utilize that knowledge to make their own decisions. Something that perhaps shouldn't be overlooked in this regard.
Sher-Lu, what are your processes to engage the patient toward the goal of smoking cessation?
So right now, I think the physicians are the ones that start the conversation, from the surgical teams to our pre-op clinic. We do have a best practice advisory. That's a standard order that we can order, and we actually will refer the patient with their agreement after the quick discussion that have someone similar to Andrea and Jillian, that they are specialized in smoking cessation. And they're going to be the one, once that order has been done, to take care of it from now on. So that way we start the conversation, but by no means, I don't think we are able to finish that conversation as the expertise in that field. So that's what we have as the current process. Make sure that the conversation and the initial education is done. And then hopefully most of the patient will agree to at least receive the phone call from the special team, the special tobacco cessation team, and then go on from there.
You mentioned the quit process.
The one that we have at the Mayo Clinic is that once the patient has identified and say, yes, they do smoke and have or vape or any tobacco use, we would, within our electronic medical system, if we order that, the best practice advisory would have the special team later make a phone call. Everything could be virtual or in person now since the pandemic started. And they will provide counseling in person or virtually and move on from there to see what kind of process or treatment that's best suitable for that particular patient. As I am no expert on that special subject, so I'm the one that say, okay, this is the best thing we can do is send them to the absolute expert that can provide those counseling and then later provide the best treatment for each patient.
So Toby, Jillian and Andrea, smoking cessation experts. In fact, they have certification in that space. And I respect that many of us do not have certification in that space. As a surgeon, how do you manage that patient who is difficult.
The most important thing you can do as a surgeon is never refuse to operate on someone. I think it's a reverse psychology. You're saying, I'm not going to operate on you because you smoke. Also, that's starting to get into ethically touchy areas. One of the things you can do that I've found amusing but effective is I tell patients that I absolutely love operating and I'm happy to operate on them whenever they want. If they tell me they want an operation, I'll do an operation. And the first reaction is they'll do anything possible to avoid me operating on them. Maybe that's a personality thing. I don't know, but it works very well. I've focused on the surgical perspective here from my view and the 2 points of the facts and the patient empowerment. In the setting of vascular disease, we have a combined clinic where we do exercise therapy with risk factor modification, and smoking cessation comes into that as well. I'm not just as dogmatic as chopping legs off as it may seem.
So,
Monty, I guess we got some Slido questions you want to pose?
We do. It's from Mark Koch. Has anyone tried to work with payers to create patient incentives, in quotation, such as reduced EOC copays, deductibles, for patients documenting preoperative abstinence? Ethically complicated again?
Well, I'll put that to Jillian because you seem to probably be most capable to answer that. I don't know if you can, but I would guess most able.
I am not familiar with anyone doing anything perioperatively, so reducing the cost of surgery or anything like that. There are lots of incentives like payers you'll have lower premiums if you don't use tobacco. There is also, we did a study, or our director did a study at where patients paid in to participate in a tobacco cessation program. And if they completed it, whether or not they quit, they got that money back. And that was in collaboration with the payers. So there are lots of models like that that exist, though I'm not familiar with any in the perioperative space.
So much to talk about. We didn't talk about vaping. We didn't talk about marijuana. We didn't talk about lots of stuff. So we'll probably just have to have you back again next year. With that said, heartfelt thanks to all of you. Great session. Thanks, Monty. Thanks, team.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.